You're listening to Case by Case, the podcast where medicine meets real-world practice, one clinical case at a time. Brought to you by a continuing education company, this series brings you front-row access to compelling case studies recorded live at top-tier CME conferences across the country. Each episode, we dive into a single, real-life medical case presented and discussed by leading experts in the field. It's medical education elevated, engaging, and deeply relevant to today's practice. This is Case by Case. Let's begin.
All right, now that we know everybody's comfortable, we're going to go to case study number 3. Okay.
Well, my mother used to ask people, are you comfortable? And they would say, well, I make a good living. So depends on what you...
It's all relatives, right? All right, so you're seeing the 61-year-old man with type 2 diabetes and non-ischemic cardiomyopathy. Terminology maybe is outdated, but I think that's okay. No. Heart failure with reduced ejection fraction. So the EF we know is 25 to 30%. Hypertension, obesity, chronic kidney disease. Just is discharged from the hospital following an acute heart failure exacerbation, unfortunately. He's had diabetes for 15 years. Due to his low GFR, metformin was stopped, and he was discharged on insulin glargine 14 units at night. Common scenario, don't know what to do. Let's send him on the insulin he was started on in the hospital. On physical exam, body mass index is 42. He has JBD to the mid-neck. He's clearly not euvolemic just yet. And we know he does have microvascular disease now with the monofilament being reduced. So when you look at his labs, his A1C is 6.8. His GFR is 33. And his fasting glucoses range from 110 to 130. He's actually checking his glucose in the morning. All right, so we're going on to the question. Which of the following is the best second agent to use in combination, at least for the moment, with glargine insulin to achieve optimal disease control? Do I have to click again, or are we good?
Yes. Yeah.
One more time. Yeah. Ooh. All right. We have a result. Aha. Dapagliflozin.
Oh, look at that.
Very nice. But look at the split with semaglutide. Okay, this is a hot topic. And I think we didn't really address it specifically today, but we are so fortunate to have a cardiologist on the stage for this one. Well, first of all, I'll just go through my perspective. So this stumps some of the board, people taking the boards, but disease control in diabetes does not mean glucose control anymore. It really includes the entire spectrum of the disease. This patient has atherosclerotic heart disease that has led to reduced EF heart failure, but all in the context of obesity and diabetes. So we're not thinking his A1C is actually pretty decent. That's not actually the problem, but he's seeing the endocrinologist. Why? Because he's on insulin. Okay. So the SGLT2 inhibitor, Dapa, right, is the evidence for reduced EF heart failure is so strong. Also, this patient has an GFR in the 30s. And actually, we now know that the SGLT2 inhibitors are safe and probably effective even at lower GFRs, probably down to as low as 20. So that's the next point here. The next point is that DAPA is not recommended to improve glucose control. So the important point here is the DAPA is not for improving an A1C at all. His GFR is too low. So remember, if you're trying to achieve glucose control with an SGLT2, you really need a GFR over 45. It's all dependent on the GFR. So again, hammering home the point, it's not for glucose control here. It's actually just for the heart failure at the moment. So let's talk about this is the hard part, I think. Yeah. This is a man with severe obesity who has reduced EF heart failure. We suspect that he'll benefit from weight loss, right? I think there's probably no doubt. The question is what the data really show in support of using GLP-1s and reduced EF heart failure. We're using it in folks who are preparing for heart transplant because their BMI is too high. But there's it's not really, we're not comfortable here yet. We're more comfortable with preserved EF. So I was hoping, Nahal, you could help us with this.
Yeah, no, Marie, you raise a really good point. I know we talked a lot about, kind of in the HFpEF talk about that obese kind of cardiometabolic profile of HFpEF and the data that's coming now for semaglutide and tirzepatide. And that data looks really, really promising. We've also talked a lot about SGLT2 inhibitors and their benefits for all patients with heart failure across EF.
Right.
Reduced and preserved. And so then you might say, well, what about the data for GLP-1s in reduced EF, right? Because what we showed for STEP HFpEF and the SUMMIT trial was semaglutide and tirzepatide for PEF patients. And it turns out, just like Marie said, it's a real question mark. In fact, there's some data or really small studies, and so it's not enough to kind of substantiate, but
And also liraglutide, so not all, we just got liraglutide data, yeah.
Where there might even be a slight worsening of heart failure events for reduced EF patients with GLP-1 RAs. Is that a clear signal? Is there going to be there's bigger studies that are sort of ongoing that are looking at that? No one knows what the exact mechanism of something like that might be. The GLP-1 RAs do cause an increase in heart rate and maybe a slight increase in sympathetic activity. And so you can think just kind of pathobiologically for reduced EF heart failure, that would be very much contrary to what we try and do with most of our other neurohormonal antagonism for reduced EF patients. And so is that part of what's going on there? I don't know, but I think Marie captured it really well, that the data for the GLP-1 RAs in reduced EF heart failure is still a little bit of a question mark. And so I think in this case, this clinical profile, reduced EF heart failure, and some CKD, I think you've got some pretty compelling reasons to add on an SGLT2 inhibitor. I don't know, Jan? Yeah.
Indeed.
Case, because I want to give full credit to the people that said semaglutide.
Yeah, sure.
Go back one.
I'm going back.
Okay. So his renal function is 33. He's got diabetes.
Yep.
He's a flow patient.
Yeah.
Flow patients not only decrease cardiovascular death, which your drug will not do.
Which one?
Your
Dapa?
SGLT2.
Yeah. Will
Right.
not reduce
It will not reduce
the death.
cardiovascular death. My drug is going to reduce total death in the flow trial. It's going to reduce kidney disease. What's his biggest problem right now? Kidney disease. I say fight the insurance company.
Yeah,
The
nice.
patient's better off with both. But full credit to the people that said semaglutide.
Oh, full credit. I totally
You know your
agree.
clinical trials. Look at the trial. Does my patient fit a trial?
Yeah.
And then that's why they do the methodology of a trial. And that's how we practice clinical medicine. So both A and B are right.
Yeah. But to your point, he would not be included in the flow trial because of his uncontrolled heart failure, I think. Right? He's not euvolemic. And so
I'm
what do you
not
think?
sure.
What do you think?
I'm not sure if that was.
They were sick. The flow patients were very sick.
Oh, they were very sick,
They
but
were
I don't
very
know if
sick.
he wouldn't. Yeah.
Yeah.
I don't.
It's just, I think we
mean,
all
that
are
is the-
agreeing. Yeah.
In the flow trial, as Kathy Tuttle, who will be with us in Charleston in June, as she told me, Jan, this trial did everything it could have. It not only preserved renal function and kept them off dialysis or transplantation, it prevented cardiovascular death and total death. What could be better than that?
Yeah.
And she's right.
Yep.
Right.
She's right. I mean, it's good to live, and they live better, and they live better. I mean, really. I mean, real quickly, when I was a third-year medical student, I was deciding what I was going to do, and I told people I was going to go into internal medicine. My friends that I rotated on all my services with said, why would you ever do that? All you're going to do is prolong disease. You're never going to be able to do anything that will really help the patient. Be a surgeon. We cut out disease. We change the natural history of disease. how far from the truth today.
Wow.
What we're doing with these drugs, if we can get them, is changing the natural history of disease.
Thanks for watching. If you found this discussion valuable, be sure to like, subscribe, and hit the bell so you never miss a new episode. To explore upcoming CME conferences and earn credits while staying at the forefront of medicine, visit cmemeeting.org. Until next time, keep learning, case by case.